Hey, this is Dr. Kaur here. I'm from North Alabama Medical Center, and I have two presentations today. And I'm going to start with the first one, which is our life-threatening hematologic emergency. I want to make sure it's the same one. Yes. So it's a life-threatening hematological emergency from low-dose methotrexate toxicity. So methotrexate is an inhibitor of cellular proliferation used in treatment of several rheumatic and autoimmune and malignant conditions at variable doses. In comparison to high doses, mainly used for malignancies, when given at a standard dose, which is 7.5 to 25 milligram weekly dose, like for rheumatoid arthritis, adverse drug reactions are extremely rare. However, under some circumstances, it may attribute to developing methotrexate toxicity, resulting in GI upset, hepatotoxicity, neurotoxicity, myelosuppression, just as how it would do at a higher dose. So literature review shows that only a few reported cases which reflected low-dose methotrexate associated emergencies. So here I'm going to present a case of life-threatening pancytopenia caused by a low-dose methotrexate because of renal failure. So we had a 63-year-old female who presented with chief complaints of nausea, vomiting, shortness of breath, palpitations, weakness for 2 weeks, and one episode of nosebleed on the day of presentation. Her past medical history was significant for rheumatoid arthritis, which was managed with folic acid along with methotrexate. And she was taking 2.5 milligrams, 5 tabs in the AM and 5 tabs in the PM, and that was once weekly. With the last dose, she had taken a week prior to the admission. She recently had a 2-week history of oral thrush and UTI, which was treated with fluconazole and ciprofloxacin, respectively. When she arrived, her blood pressure was 97/49, heart rate was 105, and she was saturating at 93% on room air with respiration rate of 20. On physical examination, she appeared frail, she was pale, and she had generalized bruising and petechiae over the anterior chest and all over her extremities. When we did her labs, that showed WBC count of 0.7, hemoglobin of 3.8, platelet count of 1, BUN of 80, creatinine of 2.9, ALP 59, AST 29, ALT 35, GFR 16, MAG 1.8, proBNP 432, troponin COVID was negative, and lactate was 5.6. Her chest X-ray, CT head were normal. CT abdomen, pelvis without contrast showed some hepatic steatosis. So she was given some IV fluids, antibiotics. She required some pressor support with Levofed, and her blood and urine cultures did not show any growth. So our final diagnosis for this whole presentation was severe pancytopenia, which we attributed to methotrexate toxicity, especially exaggerated by AKI with the recent use of ciprofloxacin. And the way we managed it was she was treated with, obviously the methotrexate was discontinued, and she was treated with 3 units of packed RBCs, 4 units of platelets, and leucovorin, which is folinic acid, which was given IV 15 milligrams every 6 hours for 4 days. And subsequently, dramatically, her labs and symptoms improved within days, within first and second day, and she was discharged home after 1 week of hospital stay. So the learning objectives from this case is that we need to identify patients on drugs who are on methotrexate before we prescribe them other new medications, especially that may increase the likelihood of drug accumulation or toxicity, especially in the risk of developing AKI. And next is, if we do encounter methotrexate toxicity, the mainstay is to discontinue the drug to maintain the hemodynamics, timely transfusions, and mainly giving the leucovorin, which is folinic acid, which bypasses the metabolic block, which is induced by the methotrexate, and it must be initiated as soon as possible for life-threatening myelosuppression as it was described above. And then I think in outpatient setting, we must implement the practice to routinely monitor the labs while the patients are on methotrexate therapy. And as per American College of Rheumatology, routine blood work should be performed every 4 weeks during the first 3 months, and every 8 to 12 weeks from 3 to 6 months, and then every 8 to 12 weeks thereafter. So this was one of the very rare cases that, I found really interesting. I've attached some references because low-dose methotrexate may not really cause all these life-threatening issues, but it may, as I have described above. Do you guys have any questions?